Hello and welcome to the Smart Connections podcast and the Talk the Path podcast. My name is Anna Sanderlin. I am a warm-line facilitator for the University of Memphis Smart Center. The University of Memphis School of Social Work Smart Research, Training, and Treatment Center aims to provide evidence-based interventions for school-based mental health programming, increase access for school-based behavioral health programming in underserved areas, offer training on best practices in telebehavioral health, develop opportunities to research the use of technology in practice, and provide direct services to the state's most vulnerable populations. You can call the Smart Center at 901-678-1636. The University of Memphis Smart Center, in conjunction with the University of Tennessee, Knoxville, and the Tennessee Department of Mental Health and Substance Abuse Services, would like to present the Pathways to Behavioral Health Careers Project. The goals of the Pathways Project are to provide education and information on the various career opportunities in the field of behavioral health through presentations, increase interest in students in the field of behavioral health, provide opportunities for guidance with information regarding college, university programming that result in degrees for professions in the field of behavioral health, connect students with students in behavioral health programs and professionals in the field for further research. This podcast will feature students and professionals in the field to give a clear picture of the daily duties of these roles and how they help support their communities.
My name is Dr. Lloyda Williamson, and I'm a child, adolescent, and adult psychiatrist. I've been in practice for almost 30 years, and I've had the opportunity to work in various settings. And I'm just always happy to connect with people to talk about the field of mental health and talk about my work in mental health and how others can be involved and be educated in terms of a career and also mental health issues. So thank you for this opportunity.
Absolutely. And thank you for being here. I guess my first question would be, can you discuss your experience working with children of different age groups and kind of how this relates to you in your field, how it kind of helps you?
Sure. So as a child and adolescent psychiatrist, I've had the opportunity, as I said before, to work in various areas. So at different points in my career, I've been in private practice. And when I was in private practice, half of the people I saw were children and adolescents, and the other half were adults. I've also had the opportunity to work in a community mental health center in the past, and that's where I'm working right now. I've worked in residential treatment centers, which are places where children and teenagers can go for extended treatment after they've been in outpatient treatment and things haven't gone well, and perhaps they experienced a crisis and were admitted to a hospital, usually multiple times, before individuals realize, these are more intense issues that don't require them to be in the hospital because they're not acutely at risk of harm to themselves or others, but they still need sort of intensive care. And so they actually live in a facility and receive intensive treatment. So with all of those different settings, and as well as working in outpatient settings at universities and an academic medical center, medical school, I've worked with kids as young as 3 to 4 years old. And usually those concerns have to do with parent issues and issues within the home or in the community, as well as working with children going up all the way through high school and college. So children and youth and young adults, I've had the opportunity to work with them in different settings with all sorts of different emotional and behavioral issues. And each setting requires a little different focus and skill set in terms of working with the kids and their parents, or if they're in foster care, involvement in terms of the foster care system and their caseworkers.
Awesome. Well, it definitely sounds like you have a lot of experience. You said 30 years in this field, but a lot of experience in different settings. So that's amazing.
Yeah, yeah. And I've enjoyed each setting.
Yeah, for sure. And just curious, what inspired you to become a child psychologist? Again, I know that you've been in the different arenas and different fields, but I guess as a whole, what inspired you to enter into that field?
Sure, sure. So, just a point of clarification, I am a psychiatrist versus a
Yes.
psychologist. Yeah. So, a psychiatrist is one who, after college, applied to and did 4 years of medical school. And then, after medical school, is when you choose your specialty. And I chose psychiatry. And I did adult psychiatry for 3 years. And then I did 2 year fellowship in child and adolescent psychiatry. So I was blessed to be able to have exposure to the medical field early on. I have several people in my family who were who practice in the medical field. My mother was a nurse, and my father was actually a psychiatrist, and he also worked in several areas, including teaching at a medical school when I was younger, elementary school age. And so I was exposed to physicians at different specialties. He taught at Meharry Medical College here in Nashville, Tennessee. And one of the things that I really appreciated about my father's work and others who worked in psychiatry and mental health is that mental health is so key to physical health and just functioning in our society. And one of the things that my father also did is he did community presentations and interviews to help people understand that mental health is related to making sure you have good nutrition, physical activity, positive social connections, staying away from illicit substances or too much alcohol, tobacco, and also connected in the importance that spirituality plays in mental health. And so as I thought about becoming a physician, it just felt good to be able to know that as a psychiatrist, I could relate to people, understanding them medically and the medical background, but then also work with them in terms of those different factors, which we now call lifestyle medicine or lifestyle psychiatry. So those positive factors as well. So not just treating patients with medication and therapy, but looking at their lives holistically. So that's what I really enjoy doing.
Yeah, absolutely.
All right. For the next one, so I know you said, you've worked with multiple age groups in multiple different scenarios, but specifically, how do you approach building rapport with a new child client? And do you have like a different perspective on depending on age, so teenagers to like younger adolescents?
Yes, excellent question. So generally speaking, you'll hear that my work has been on an outpatient basis versus in the hospital. And so when I meet with children and teenagers for the first time, they're usually being brought by a parent or guardian. And usually I'll have the parent and the child or the teenager in the room at the same time. And we explain the process of what's going to happen during the appointment. And then I usually turn to the child first to ask a little bit about what's going well in their lives and then what's not going well, to just see what they will share. And then if they don't share about some negative things or some problems, I'll ask them about that. So I'm trying to get their perspective. Right. And you'll be surprised. Kids as young as 5 or 6, by the time they get to me, they can often say that, well, I'm getting in trouble at school or at home, or I'm feeling sad. And so being able to have that connection with them early on in the process helps me to be able to establish rapport with them. With teenagers, sometimes it's better to start with everybody in the room together, and then ask the parent to step out so the teenager can share alone without disclosing everything to the parent. So I'm using language according to their developmental level that they can understand, but then also giving them the opportunity to talk about what's on their mind.
Absolutely.
Mm-hmm.
You for that. I love how you talked about speaking the language that they can understand. That is so important when dealing with different age groups, and not talking to them as a grown adult, rather meeting them at the age and the place that they're at.
Absolutely. Yes.
Yeah. So do you mind sharing a little bit more about what the assessments are like and what that process is for the children that you work with?
Okay, sure. So as a psychiatrist, our assessments are usually interviews, talking with kids and teenagers and their family members or guardians, and then observations, right? And so I'm not necessarily having them do tests on computers. Sometimes they may fill out a form so that I can see what sort of symptoms they're experiencing. But there's a structured set of information that I need to obtain from them. So what's going on with them now? What sort of mental health issues have they had in the past? What family mental health issues, family medical problems, their own medical problems, going back and talking to the parents about what happened before they were born in terms of the family circumstances, during birth, how they developed in terms of learning to walk, crawl, talk, even potty training. Those things are important. And then who were they with in terms of childcare, how they went through school developmentally. So I'm asking about all of that information. And then we get to a point of what we call a mental status exam, where I ask more specific questions to see how they remember things, how they can calculate. One of my favorite issues or one of my favorite questions to ask kids and teenagers are 3 wishes. If you had a wish for anything, 3 wishes for anything, to do anything, be anything, have anything, change anything, go anywhere, what wishes would you have? And that gives me the ability to see how much do they think about and wish for changes related to their problems, or are their wishes totally unrelated to their problems? It tells me a lot if they can't even think of any wishes, or the kind of wishes that they choose can also help me understand their intellect and ability to solve problems. So if a person says, for example, I wish to have unlimited wishes, that tells me one thing versus a adolescent wishes to have a home or to be able to be back in their home with their parents who and wish they'd never be divorced. Those answers tell me a lot. And then take all that information and I'm sorting through what are the possible issues or problems that could be related to this. Is it depression? Is it anxiety? Is it attention deficit hyperactivity disorder? Or are they experiencing some intellectual disabilities? How are they coping with things like abuse? And then we develop a treatment plan. What's the best way to kind of approach this? So that's the assessment process.
Absolutely. I would like to say I love that you do the 3 wishes.
Yes.
Because I know, especially for younger children, it can be hard for them to express themselves, especially when they're with a new adult and it feels like an interrogation. So by doing this, you are meeting them at their level, which I think is wonderful. And just to kind of keep following on with the assessment process, how do you include either the family, parents, guardians in the therapy process with these kids?
Mm-hmm. Sure. So as I stated before, usually for the first appointment, I'm meeting initially with the parent and the child. Sometimes there's some information that the parent needs to share with me that it may not be appropriate to discuss in front of the child, or if they discuss it, the teenager may get angry and upset. And so I'll ask the child or the teenager to step out so that the parent and I can talk alone. And then we'll bring them back in, the child back in, and have the parent step out. So that's the initial appointment. And then follow-up appointments, again, having conversations with the parent or the guardian. How do you think things have been going on? And then see how that lines up with the child. So it's very much with children and adolescents, you can't just see the child in isolation. You have to understand family dynamics and changes, parent separations, moves, divorces, parents' own medical problems, death of grandparents or other relatives. Those things all affect how the child is functioning. And sometimes the child doesn't talk about those or doesn't realize those things are important. So it's important to get that information from the parent.
Absolutely. I do have our next question is, can you provide an example of like a successful intervention that you had implemented with a child with behavioral issues?
Sure, that's an important issue, a question, definitely important question. So often when children of all ages, either younger or even into adolescent ages, are having behavioral issues, it may be related to a disorder that the child or teenager is having, but it also may be related to family dynamics. So, for example, if a child is acting out or hitting someone or refusing to do chores or refusing to do homework, that often requires some external parameters and monitoring by the parent. And sometimes the parents are so frustrated or overwhelmed, they need some guidance in terms of how to do that. So talking with the parents about providing rewards for positive and appropriate behaviors, but then also making sure they know that they have some power in the house to be able to provide consequences for inappropriate behaviors. And sometimes when you ask parents, well, what are the consequences? They say, well, I told him and I yelled at him, but that's not a consequence. Consequence is removing cell phone, removing access to electronics, removing access to the car. And those things get the child or the youth's attention. Now, they may not like that at first, and they may get more disruptive. But if the parent is consistently placing those parameters, well, first of all, discussing them ahead of time. These are the rules. And if you break the rule, this is the consequence, and follows through with that. Generally speaking, the child realizes, oh, this is a new game. They're serious now, and they're going to hold me to it, and they will eventually comply. So when we have those follow-up sessions, talking with the parent, how did you do with implementing those consequences? And I'll give an example. If you go driving down I-40 at 100 miles an hour and you get pulled over by the cops, and the cops say, I'm giving you a $200 ticket. And the parent says, oh, no, please, I was not paying attention. Please don't give me a ticket. And they're let off the hook. Then they may be less likely to not speed in the future. But if they have the consequence of that $200 ticket and you have to go to court and take off work to do that, then they'll pay attention. Same thing. You got to follow through with the consequence so that those children and youth understand that you're serious. So Absolutely. I think that's one of the biggest examples in terms of helping parents and children work together to improve behavioral issues.
Consistency is key. I know that's something that's repeated often in the social work profession and other professions we're helping, mental health. So consistency is always one thing that we want to, make sure that we're staying on top of, so we completely understand.
And I know that you said giving rewards. So if they followed through with that, giving praise. I'm really proud of the way you did the dishes when I asked you to, or took out the garbage. Great job. And yeah, so now you can earn your right to have your phone back or your,
right.
Yeah.
Absolutely. I know we've all been teenagers. I'm sure most of us have probably been in that position where we got our phones taken away or our cars taken away. And I don't know about anybody else, but it definitely kept me from going down, doing what I was doing at the time.
Right.
So I know you said that you have been in this field for 30 years, and I just want to ask, how do you stay current on research and developments in child psychology or psychiatry?
Sure. Excellent question. So there are some parameters in order for me to maintain my license. I have to have a certain number of continuing medical education credits, and those can be obtained by reading articles and submitting them to professional organizations, or going to conferences and attending conferences to learn about different types of therapies or medications or brain development. And then the big one is, after I completed my fellowship training, I had to take an exam, which is a board certification exam. And once you pass that exam, you're certified. That means I know what I've trained to do. And then every 10 years, I had to take an exam to recertify. A new process this year is that we're reading a certain number of articles. So people have the option to either take the exam every 10 years or every 3 years, read a certain number of articles and take a quiz on each article, and then submit that information. So, nice. And then of course, you can attend different lectures and read magazines and journals in the profession to just stay up to date.
Absolutely. I did not realize that the different increments and that pays into all of staying or keeping your license, rather.
Yes.
Well, that's good to know. So for the next question, kind of shifting gears just a little bit, I know we kind of discussed like the success stories or how to move forward in intervention and sessions with a child. Can you give more of an example of a child who seems to be more reluctant or not as engaged? And how do you handle situations with that child who are kind of resistant to treatment, to therapy?
Yes, that's an excellent question. So it is true that everybody who comes for an appointment, either children or adolescents, are not necessarily happy about being there or want to be there. And so I'm usually trying to find some common ground. All right. So if there's a child who's shy, usually just trying to interact with them. I do have in my office different items that kind of can break the ice. So I've got things like Uno cards, so we can play Uno, or I've got a dollhouse, and sometimes they'll go play with the dollhouse or different puppets with younger kids to kind of break the ice. And often when you break the ice, they may start to talk about, the problems that they're having at school or problems they're having with their parents. One thing teenagers often, if they won't talk about those problems, they will talk about what they don't like. Like they don't like their teacher, they don't like their school, they don't like their sibling. And then maybe from there we can shift to talking more. Sometimes it actually takes a couple sessions of just sitting there quietly before they'll open up and say, well, I really don't want to be here. I don't like being here. Let's talk about why people think you need to be here. And then we can go there. So sometimes it takes a while, but there are usually different methods to kind of break the ice with them.
Absolutely. And I also think that highlights a lot of patience on your part to be able to sit through those sessions, knowing that they don't want to be there, but you still have to try and get that interaction in with them.
Right.
Let's see.
Mm-hmm.
So I know, in working with children, they have many other factors in their life that they have to deal with: school, at home, if they're in any kind of extracurricular. So how do you work around and collaborate with other professionals, such as maybe, their teachers, their pediatricians, principals at their school? How do you manage those situations?
That's an excellent question again. So in terms of like pediatricians and primary care doctors, like family medicine doctors, sometimes kids are experiencing emotional or behavioral problems because there's an actual medical problem going on. So we want to make sure that they're maintaining those regular appointments to treat those other disorders, whatever they may be, problems with their thyroid or problems with weight or problems with diabetes, for example. And then most frequent ones that we have interaction with are their teachers. So sometimes if they've been having problems at school, we may get an email or a report from a teacher. We do have to sign release of information so that we can talk with the teacher and the teacher can talk with us, and the parents and or the adolescent will sign off on that release of information. And then we can send forms to the school that the school will fill out and complete and provide us with information on if things are improving or not improving. Another way that we interact with the school system regularly is that if kids and teenagers are having difficulties keeping up with learning in school, there can be different plans like an individualized learning plan or a 504 plan that the teacher and the parent meet with to set some guidelines or what are the goals for this child to be able to learn through this school year. And they meet at the beginning of the year, set those goals, and at the end of the year, discuss how those goals have been accomplished or not accomplished. The individualized education plan can be ways that if children are experiencing disruption or anxiety, there's a plan so that when an incident happens at school, they can be excused and go to the principal's office or the counselor's office so that there's a plan in terms of how to deal with things at the school system. So there are various ways that we communicate with the school and with other medical providers, and as well as therapists. So while I'm trained to do therapy, most of the time I'm not the primary therapist. I may do some therapeutic interventions and interactions during my session, but I can also get a release of information signed so that I can communicate with the child's therapist and understand what's happening more intensely in that therapeutic session, those therapeutic sessions.
That's beautiful. I'm glad you mentioned that you're not always necessarily the primary therapist. Earlier, you mentioned having some Uno cards and things like that to maybe break the ice. And I was thinking, oh, that's a little bit of play therapy going on in there.
That's right. That's right.
Yeah. That's awesome. So I'm sure, of course, in your experience, you've come across or worked with children that come from different cultural backgrounds. Can you talk a little bit more about your experience in that area? Like, was it difficult? Is there any differences or is it pretty much the same? Yeah.
Yes. So that could be a whole other podcast in and of itself. But what I will tell you is that, yes, there can be some differences. So the majority of the children I work with, children and youth, are Caucasian background, but I do work with a significant number of children who are Black, who come from various backgrounds, whether they're Caribbean or African background or American family heritage, as well as some Hispanic and some Asian families. And the experiences of those children can be different according to the community in which they live. So, for example, there have been some times that I worked in more rural areas in Georgia or Alabama, and the experience of those children in terms of having access to resources, therapists, and feeling that therapists understand who they are and the challenges they may have in terms of being a minority at a school may be different than if they were in a larger city and they're going to a school where there are more minorities in their school. It also makes a difference in terms of the schools that they attend. So sometimes public schools can be very different. Minority schools where you have a large number of minority children may be in inner cities or in communities that the schools are less funded well. And so they don't have books, they don't have computers, they don't have all of the athletic equipment that other schools may have in communities where there are majority Caucasian children, where their parents have the resources to put more money into the school. And so there's a difference in funding. So that's one difference. I can recall an adolescent that I worked with within the last couple of years that was a very bright student and did well academically. She's in a public school, but she was just one of a few Black teenagers in her high school class. And as we talked about what she was going to do after she graduated and where she was going to go, she mentioned pretty much exclusively predominantly white institutions, and did ask her, because we had talked about her feeling isolated as a Black teenager there at her high school. I asked her, had she ever thought about going to a historically Black college and university, an HBCU? And she said no, she'd never thought of that because she felt like if she went there, she would still feel isolated because students who go to HBCUs have always been around other Black students. And so she would have felt excluded. And so I had to tell her, actually, that's not true. Many students go to HBCUs because they haven't felt included in their high schools and they wanted to get a Black experience. And so just the perspective of her, what she thought about HBCUs and who went there was colored or limited by her experience at her predominantly white high school. So there's all sorts of ethnic and cultural issues that can be discussed with kids and teenagers based on their family, based on the community in which they live, based on the schools that they attend in the background.
For sure.
Absolutely. And I know you work out of Nashville. We are through the University of Memphis, and I know the University of Memphis in general has a great population of people of color. So I know, especially my experience here at the University of Memphis has definitely been one that's extremely culturally diverse. So I do think pushing students that are still in their adolescent years towards something that might be more culturally diverse for them is a great opportunity for them to see more of the world and to learn more things. So I know we've talked a little bit about kind of the interventions that you use during your therapy process, but how do you track progress for your clients in therapy sessions?
Sure, that's another great question. So with any of the children and teenagers and youth we see, when they have a diagnosis, there are specific diagnostic criteria that are met to have a diagnosis. So for example, if somebody has a diagnosis of major depression, I've noted or documented whether they're having problems with sleep, interest in activities that they usually enjoy, feeling inappropriate guilt for things that they were responsible for, their level of energy, their ability to concentrate, their appetite, their their irritability or agitation, and then their thoughts of suicide. So, along with depressed mood. So, we're thinking about, and I'm documenting each of those symptoms. So, as we meet in therapy, as I prescribe medications, if they're receiving medications, in subsequent sessions, I'm documenting which of those symptoms are improving. Are they sleeping better? Are they eating better? Are they interacting more? Are they isolating less? And I'm also asking them about their experience of the treatment. How do you feel things are going? Do you feel things are improving? Are you now connecting more with friends? Are you interacting better with your parents and your teachers? Are you interested in getting your schoolwork done, able to concentrate? So those are the ways that I evaluate and document in the chart, in their record, how things are going.
Okay. Yeah, very thorough. Gotta be. I mean, that's kind of, you have to, especially with your profession, to be very thorough and current with all of your notes. So
absolutely, yes.
Yeah. So with that, how do you address confidentiality concerns when working with minors, as you're working in conjunction with maybe their primary therapist, maybe the school social worker or their parents?
Yes. So confidentiality is definitely important, particularly when you're dealing with youth and some issues that are difficult to talk about, whether it's depression or suicide or issues of abuse, physical abuse, sexual abuse, neglect. And so up front, we let them know that these are the people on their team in terms of their therapist, myself, pediatrician. And so it's important for us to understand them holistically and for them to sign consent for us to communicate with them. But we're only and also confidentiality with the parents. We'll communicate what's necessary for people to understand about what's going on with them. So I'm not necessarily going to talk with the parent about everything they talk about in the session, unless I'm concerned about their own safety or the safety of other people. And then I'll let them know ahead of time, these are the things I do need to let them know because of safety issues. But if there are other important things that they don't want their parent to know, but I think is important, that are not life and death, I'll say, you know what, I do think we need to discuss this with your parent. And these are the reasons why. And they may or may not agree. So sometimes there may be some sessions where there are some things that are important for the youth, but I'm not sharing it with other people because they're not at the point that they're really ready for other people to know about it. So it can be a process as well.
Mm-hmm.
Absolutely. Sometimes it's definitely a hard line to walk, knowing, is this something that I need to report? Is this something that the child can handle, that we can work with together? So I completely understand.
Yeah.
And I know we have actually already touched on this a little bit about play therapy, but what role does play therapy have in your practice?
Yes. So play therapy is a way to break the ice, as I mentioned before, but it can also be a bridge for children and youth to talk about or express some thoughts about some really challenging situations. So I've had kids, and you'll be surprised that, some teenagers might also gravitate to the dollhouse with the dolls, and they wouldn't necessarily play with them in the same way that a younger child might, but they may act out or discuss family relationships that are difficult or family boundaries. You can learn a lot in other sorts of games where kids are having difficulty following rules. So kids cheating when they're playing Uno, and they're cheating, and you waiting to see if they're going to fess up to that, or they can't lose, so they always got to figure out a way to win or end the game, drop the cards when they're losing. So it tells you a lot about their own internal thought process and how they solve problems and deal with conflicts.
That's really good. Yeah, for sure. As we kind of wrap up a little bit, we do have maybe 2 more questions for you. How do you adapt? How do you adapt your communication style when speaking with younger children versus adolescents?
Yes. So as I think about that question, one of the things that comes to mind is a subject that we always have to discuss with children and teenagers and even young children, and that is suicide. So younger children may not really understand what suicide means, but if they're really struggling with thoughts of depression or having had experienced abuse or neglect, they may have some sad feelings. And so our introductory question might be, as we talk about how things have been going, I want you to tell me, have you ever felt sad? Have you ever felt so sad that you didn't want to be around anymore? Have you ever felt so sad that you had thoughts of hurting yourself? If you have, what things have you thought about doing? And what did you think would happen if you scratched yourself or cut yourself or jumped off the bed? And so even if a child has an action that wouldn't necessarily have harmed them or caused death, but they wanted that to happen, that gives me the ability to understand that this is really serious. Whereas with an adolescent, I may actually talk more about, have you viewed anything, in terms of social media, talking about suicide? Have you thought about suicide? Have you attempted? If you've attempted, what happened after you attempted? Did you tell anyone? So, the way and the language that's used for something such as a discussion about suicide or harm to self or harm to others is geared to the developmental level of the child.
Absolutely. And those are extremely difficult conversations to have, especially when they are on the younger end and they don't fully understand it quite yet.
Right.
But for our last question of the day, how do you handle disagreements with parents or guardians regarding the child's treatment plan?
Sure. So I think the first thing is to understand where the disagreement is coming from. So if there's been a recommendation for example, medication, like a child is experiencing moderate to severe depression, that we really think medication would be helpful, and the parent says no, I want to understand a little bit more about what their concerns are, what their worries are, and sometimes they're worried about the child getting addicted. And so I talk about the different types of medications and how the medications we use for depression aren't habit forming, and that while there are some other medications there that may be. And they said, well, they read online that somebody took the medicine and they stopped and they went through withdrawal and they had side effects, and so they were addicted. I explained the difference between addiction and withdrawal and having side effects if you abruptly stop a medication. Other times it might be that a parent heard negative things about a particular medication. Well, Uncle so-and-so took that and that's why he was crazy, or that's why he went off his mind. Or so I try and use appropriate terminology that, we may not know exactly what was going on with Uncle so-and-so, and while he may have had some difficulties, we don't want to use the term crazy, but we want to use terms that support actual medical diagnosis. And then let them know that, okay, if you don't want to use that medication, there are other antidepressants that we can use. So trying to understand where they're getting their information, provide them with resources. So, for example, the American Academy of Child and Adolescent Psychiatry has a website, and you can go to a specific site, Facts for Families, where they can get information about diagnoses, assessment, treatment options, and understanding the full breadth of what is involved with treatment. So if somebody has mild depression, okay, we may not recommend an antidepressant. But if they have moderate to severe depression that's interfering with their ability to function in school, they're failing classes, and there's lots of arguments at home, or they're isolated, or they're having thoughts of suicide, yes, I'm definitely going to recommend medication in addition to therapy and making sure they're eating wholesome foods, getting adequate sleep, physical activity outside. So I try my best to make sure we're discussing medication as a part of treatment, comprehensive treatment, instead of the only treatment.
Absolutely. All right. Well, Dr. Williamson, it has been absolutely wonderful talking with you today. You have provided us with so much insight into the psychiatry field. Before we fully log off, do you have anything to say to any of our listeners, maybe some college students looking to go into psychiatry? Any tips and tricks?
Sure. So I think a lot of times people have a skewed view of who a psychiatrist is and what they do. So we're not just people that sit in an office, nodding our head, saying, let's talk about your mother, let's talk about your background. That can be a part of it, but we're really working with people comprehensively to help them function better. And I think a child and adolescent psychiatrist in particular can have a variety of areas to practice, a variety of ways to interact with children and adolescents. And yes, I get to play during my sessions with my kids and teenagers. And so that provides some variety for my day. So it is a very hopeful, optimistic profession to work with kids to try and resolve problems before they get to adults. And there's a huge shortage of psychiatrists and even greater shortage of child and adolescent psychiatrists. So think about that as an option. And
absolutely.
I've enjoyed it. Yeah.
Well, wonderful. For any of our listeners out there, if you hear that, maybe think about going into psychiatry, child psychiatry. It sounds like we need some more. And Dr. Williamson, thank you again for taking time out of your busy schedule. Yeah.
One more thing. We are real doctors. So we have the medical school experience, and we do assess people to see if they're also simultaneously having medical problems that are leading to their emotional and physical symptoms. So yes, we're real medical doctors.
And that's wonderful extra information. So yes, they are certified.
All right. Thank you. It's been a pleasure to talk with you all today.
Thank you so much.
You have a good rest of your week. Okay.
Okay. You too. Bye-bye.
Bye-bye.
Thank you so much for tuning in to listen to our podcast, brought to you by the Smart Connections podcast from the Smart Center at the University of Memphis, as well as the Pathways to Behavioral Health Careers Project. If you or anyone you know needs any information from the Smart Center, please contact us at 901-678-1636 or email us at smartcenter@memphis.edu. You can also learn more about us at our website, memphis.edu/smartcenter.